So last time we looked at the dermatoses that were specific to pregnancy, and this time we're going to kind of broaden it out a little bit. So go to the next slide. So again, just of all the organ systems we deal with, we're often the least familiar with skin, but it can be incredibly informative, telling us vital clues about what might be going on with our patient. Next slide. Here's kind of my medical student's guide to the practice of dermatology. It's very repetitive, so you just have to look at things over and over again. If you see a rash that's dry, wet it. If it's wet, dry it. Apply topical steroids. If that doesn't work, apply systemic steroids. And if you have the opportunity, just do an excisional biopsy and get rid of it. So there's dermatology in a nutshell, and all my dermatology colleagues would be mad at me for saying all that. So today we're just going to kind of look at the skin effects of pregnancy, conditions that affect pregnancy, and then lastly, just generic conditions that can show up in any patient, whether they're pregnant or not. Next slide. So let's look first just at common skin changes. Next. So this patient shows up, she's pregnant, and she's complaining about these spots on her face. Next slide. And this is known as melasma, or the mask of pregnancy. Some people called it cholasma in the past. It's common to pregnant women, women taking birth control pills or hormone replacement therapy. You can treat it with tretinoin cream if they're not pregnant, but in most cases, you just tell them to try to stay out of the sun, use sunscreen, and it will likely improve after the pregnancy is over. Next slide. Next slide. So-called stria gravidarum, or stretch marks, kind of a misnomer. Next slide. Not really known exactly what causes it. Doesn't seem to be due to stretching per se. Might be related to adrenal activity. Lots of over-the-counter preparations are sold, none really proven to be effective. Not a lot you can do about it. Pretty benign, just cosmetic. The incidence of acne goes up in pregnancy, thought to be just hormonal effects on skin glands. Next slide. But this can be very upsetting to patients, and I do just refer them to dermatology to get this treated. Next slide. The most important thing, obviously, is Accutane is forbidden. It's a class X drug, so you should never take it in pregnancy. And in fact, if you take it and you're female at reproductive age, they usually require you to be on 2 different forms of contraception just to prevent pregnancy. Next slide. So what's this little red bump with these capillary-like projections? This is a spider nevus, common in pregnancy because it's driven by estrogen effects on capillaries. Next slide. Next slide. You can compress these and they'll vanish, so they'll blanch, and that will help you make the diagnosis. Next slide. And often the patients will also just have palmar erythema related to estrogen levels. Next slide. What is this thing? Just this bump pops up, might be related to some minor trauma. Next slide. It's called a pyogenic granuloma, which is a misnomer because it's neither pus generating nor granulomatous. Next slide. It's more accurately called a lobular capillary hemangioma. So just a tuft of blood vessels. Etiology not totally clear, often associated with minor trauma, maybe an infection, an imbalance of angiogenic factors, pre-existing vascular anomalies. It's not really clear. Treatment is an excision, and if it's on a cosmetically sensitive area, then usually a shave excision with some electrocautery. Next slide. All right, let's look at some diseases that actually can have an impact on pregnancy. So this woman is not happy about this rash that has broken out on her face. Next slide. So this sort of malar distribution of this rash, possibly associated with other symptoms and rashes on other body parts. What do you think this might be? Next slide. So this is the malar rash of lupus, and we're very familiar with the complications that this can bring to pregnancy: fetal growth restriction, stillbirth, preterm labor and delivery, worsening of their lupus symptoms, restrictions and medications that can be used to treat lupus, a transient neonatal lupus-like syndrome, and in rare cases for patients that have SSA antibodies, the possibility of fetal heart block. Next slide. This kind of looks similar to a malar rash, but it's not. It's usually seen in much younger patients, usually in the pediatric population. Next slide. At least this facial rash is. Adults will often get this sort of reticular rash on their extremities, or no rash at all, and maybe just arthralgias. Next slide. So this sort of reticular rash on the extremities in adults. Next slide. So this is known as fifth disease, or erythema infectiosum, due to parvovirus B19 infection. And it's called fifth disease as the sort of holdover from these febrile illnesses of childhood that now have all sort of been elucidated. And for whatever reason, fifth disease is the only title that has persisted into the present day. Next slide. We really worry about this in pregnancy because we know the virus can attack red cell precursors in the fetal bone marrow, leading to severe fetal anemia, high drops. Next slide, and even potential fetal demise. Next slide. What's really been a marvel to see in my career is how Doppler assessment of blood flow in the middle cerebral artery has helped us screen and evaluate these fetuses, let you know which ones are becoming critically anemic, which ones can just be followed. Next slide. So in the lower left, you see an accelerated peak systolic velocity in an anemic fetus compared to a normal one on the right. So this really helps you decide which fetuses need fetal transfusions, which ones can just be monitored. Within a couple of weeks, the viral infection will be self-limited and the fetus will recover. So they usually, if they need a transfusion at all, and many of them do not, you can usually get by with a single one, maybe two at the most. Next slide. So this is described as being a dewdrop on a rose petal. What does that bring to mind? Next slide. Varicella infection. And I have two concerns about this and when it occurs in pregnancy. Next slide. One, I've had several patients develop a severe, almost fatal varicella pneumonia. So that's one thing I worry about. You can see the ET tube in her trachea there. And next slide. And then there is an association with scarring or cicatrix formation in the fetus. The risk, in my understanding, is a little less than 1% or about 1%. So it's a pretty small risk, but it can be quite devastating if a fetus contracts it. All right, this looks painful. It looks horribly painful, but it's completely painless. What the heck is it? Well, it's a chancre, which is a marker of primary syphilis. Here's the Treponema pallidum organism. And if that's syphilis, then who's the distinguished German gentleman on the right? Does anybody know? This is Paul Ehrlich, who came up with one of the first antimicrobial treatments for syphilis. He modified the arsenic compound to make it not poisonous to the patient, but poisonous to the organism. Next slide. And if you go far back enough in your family tree, you might find somebody who's had syphilis before, before it was treatable. Next slide. And these are just some manifestations of secondary syphilis, which is where it's gone from primary infection to a hematogenic spread. So all these lesions that we're going to see here are just loaded with spirochetes. So they get this palmar or plantar erythema. Next slide. So-called moist warts or condyloma lata. Next slide. Papular eruptions anywhere on the body. Next slide. Mucus patches in the mouth or moth-eaten alopecia of the scalp. These are all manifestations of secondary syphilis. Next slide. And then tertiary syphilis, which we rarely see, bubo formations, draining sinuses. Next slide. And then, of course, what we really worry about is if you don't make the diagnosis, then there could be a child born with it that could develop congenital syphilis, which used to be a huge problem in the past. Next paragraph, next slide. Important to know the drugs like erythromycin, which actually can treat syphilis, do not penetrate the placenta well, so they're not good for preventing congenital syphilis. Next slide. So even if a patient has a penicillin allergy, it's recommended to desensitize them so you can treat the syphilis with penicillin. Next slide. And we're all pretty familiar with how rates of congenital syphilis have been going up as the infection rate itself has been going up. Next slide. All right, gonorrhea. Next slide. The one thing I'd like to point out with gonorrhea in pregnancy, especially if it occurs beyond the first trimester, where the access to the uterine cavity and the fallopian tubes has been blocked. Occasionally, patients won't present. They won't have any symptoms. They don't develop pelvic inflammatory disease. What they may get instead is disseminated gonococcal infection, which may just show up as a relatively benign looking lesion like this. Next slide. Or like this. So just be aware, pregnant patients in the second or third trimester, not super common, but they can sometimes show up with disseminated gonorrhea. Next slide. And then, of course, we worry about the newborn coming through the birth canal, contracting conjunctivitis from gonorrhea. Next slide. Now, this looks painful, and it is painful. So this is an oral herpes outbreak. Next slide. So we really worry about this infection in pregnancy. Next slide. Due to its potential to infect the newborn. So here's a herpetic finger whitlow, and it's always important to tell your patients if they have it, don't cross-contaminate, don't scratch this lesion and then touch your eye, because eye infections with herpes can be incredibly difficult to treat. Next slide. But what we're really worried about is the neonate, extremely high mortality rates for newborns delivered through an active herpes outbreak, mainly primary herpes, and much less so for secondary or recurrent herpes. And so, like, in my mind, the worst case is the delivery occurs, and then the next day you diagnose an outbreak, a new outbreak, primary herpes in your patient postpartum. That neonate is an incredibly high risk for complications and mortality. So you have to let the nursery know immediately, and they need to start treating the newborn. Next slide. So this is so-called dry warts or condyloma acuminata due to human papillomavirus. Next slide. All right, so lastly, we're just going to look at generic skin conditions that can occur in any of your patients, pregnant or not. Next slide. So leaflets 3, leave it be. This is poison ivy, poison oak, poison sumac, and you can see that linear trauma with the rash in it. That's the Kebner phenomenon, remember from last time, very common with rhus antigen plant poisonings like poison ivy. Next slide. What has more P's than pup? Next slide. These are the 5 P's of lichen planus. It's planar, polygonal, pruritic, purple, and papular. Next slide. It also can demonstrate the Kebner phenomenon. You see a linear formation there. So that's the lichen planus. Next slide. This patient shows up and she says, yeah, like a week ago, this little round patch showed up. And then every day thereafter, I started having more and more of these lesions all over my body. Usually occurs in the spring or the fall. What do you think this is? Next slide. Pityriasis rosea, thought to be due to a viral or bacterial infection. So the hallmark is this so-called herald patch, which is where it usually first shows up. They say that sometimes it'll have this sort of Christmas tree-like distribution on the patient's back. I can never see the Christmas tree, but I guess if you use your imagination, you might convince yourself that it has that. So that's pityriasis rosea. Self-limited, benign, doesn't affect pregnancy. Next slide. All that glitters may not be gold. Next slide. It could have some nickel in it, and lots of patients have nickel allergies, and so they can't wear cheap costume jewelry. They have to have like pure gold. So it'll show up around pierced ears, pierced navels, sometimes just even a bracelet or a necklace. Next slide. So this shows up often on elbows and kneecaps. Next slide, gluteal folds. Next slide. So this is psoriasis, which is very traumatic for people, difficult to treat. Next slide. And then this sort of mild acne-like rash on the face or the nose. Next slide. Is acne rosacea. Next slide. Usually on the malar surface or the nose. Next slide. And over a lifetime, you can get the W.C. Fields rhinophyma disfiguration if it's left untreated. Next slide. So sometimes just in pregnancy, but especially patients on steroids or immunosuppressive drugs, they can get candida infections in their mouth, known as thrush. Next slide. Usually treated with just an antifungal mouthwash. Next slide. So this is dark hyperpigmentation in skin folds. Next slide. It's known as acanthosis nigricans, associated with obesity and also with patients that have obesity-related insulin resistance. The important thing for me is just there is an increased risk of lymphoma and cancers of the GI or genitourinary tracts. Next slide. Sometimes we give the patient the rash by the medications we prescribe to them. So just a good drug history is always important for patients who present with either generalized or fixed rashes. Next paragraph. Next slide. So they can sometimes be these fixed eruptions or generalized. Next slide. These are some of the drugs that are commonly associated with it. And some of them you can get a photosensitivity reaction, especially antibiotics like tetracycline. So you always have to advise them to either ideally not go out in the sun or certainly wear sunscreen if they have to. Next slide. And then there's severe forms of this, some forms of erythema multiforme, or what can even be referred to as Stevens-Johnson syndrome. Next slide. Can show up. I've had a patient who literally peeled head to toe because she had a reaction to her seizure medication, her Dilantin. Next slide. What do you think about this bizarre rash that just seems to stop right in the midline? Very bizarre. Just right at the midline, it just stops. So herpes zoster. Next slide. It's important to cover it while it's new and potentially infectious. Next slide. You want to keep them away from pregnant women, premature infants, or anybody with an immunocompromised condition. Although acyclovir may not really change the course of the outbreak, it can absolutely prevent what's known as post-herpetic neuralgia. So untreated, patients can be left with lifelong nerve pain related to this. So that's the rationale for treating them. And of course, the CDC is recommending vaccination for anybody 50 years old or older to prevent shingles that could lead to this lifelong complication. Next paragraph. So this might be exacerbated just by shaving, but these little bumps with a sort of a central crater caused by pox virus. And this one in a ring formation is known as ringworm. So a skin candida infection. Next slide. It can sometimes be over the whole body. Next slide. Next slide. And then sometimes it has this peculiar presentation where it's lighter on darker skinned and darker on lighter skinned individuals. Next slide. That's known as tinea versicolor. And if you scrape it, look at it under the microscope, you'll see this characteristic spaghetti and meatballs appearance. Next slide. So there are a couple of insect-borne infections that are important to know about. Next slide. So high fever, horrible headache, a rash breaks out in the wrist area or the hands. Which state has the highest incidence of this in the country? Next slide. Well, it's called Rocky Mountain spotted fever, but it's rarely seen in the Rocky Mountain states today. Actually, North Carolina has the highest incidence, and we're not far removed. So it is definitely something that you might encounter in your career if you're practicing here on the East Coast. And it, in rare cases, can be rapidly lethal if untreated. So it's an important infection to know about. Next paragraph. Another tick-borne illness associated with this rapidly expanding target lesion called erythema chronica migrans. Next slide. So this is Lyme disease, and physicians have made entire careers out of treating patients who have this infection associated with just a wide array of bizarre symptoms that often gets misdiagnosed or underdiagnosed. Next slide. And then sugar bites, red bugs, especially in the spring, incredibly itchy. Next slide. Or scabies infections, so in between the fingers. Next slide. Yeah, next slide. So right in the center, that little light streak, that is a burrow. That's where you're going to find the organism. So if you're going to make the diagnosis, you're going to scrape unroof this burrow. Next slide. These are the areas where you might find it. Next slide. And when you look at it under the microscope, you're probably not going to find the actual scabies mite. They're hard to find. What you'll probably see are eggs and feces. So that's what you're looking for on your skin prep. Next slide. I like to spot these in young tourists in Europe that are staying in youth hostels. So they get these 3 bites in a row: breakfast, lunch, and dinner. Itchy, 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 associated with staying in youth hostels. But I actually got this in a 5-star hotel in Washington, D.C. Next slide. So these are bed bug bites, and apparently very difficult to eradicate these from your house. So this is why they say when you travel, don't unpack your suitcases and put it in the dressers of the hotel room, because the bugs will get in your laundry, and then you'll take it home, and then your house will have it. So people used to put the posts of their beds in buckets of water, thinking that would keep the bugs out of their beds, but they just climb up on the ceiling and drop into the bed. So the only way to really deal with it is to have an exterminator come in and eradicate them. It said they can live up to 6 months without a blood meal. So you can't move out of the house and starve them to death. You really have to have them exterminated. Next slide. All right, I think that is it. So we can just stop right there with the didactic portion.